Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now, let's get started. Today, we're going to dive into the scientific publication with the title Splenic Artery Aneurysm Occlusion by Overlapping Gore Viabahn Endoprosthesis Devices. A piece of cake, or once in a while, a real challenge. Nando Merteniet, Amgad Al Mekabadi, Golem Reza Afaridi, Carlos Buitrago Teles, Pascal Kissling, Stephanie Garney, Frank Mosler, and Gerd Nolch. Introduction. The first lienal artery aneurysm was discovered and described for the first time in 1770 by the Frenchman Beaussier during an autopsy. It was first visualized using X-rays in 1920 by the physicians Akbulut and Otan. The first surgical treatment of a splenic artery aneurysm was performed by surgeons MacLeod and Maurice in 1940. The first minimally invasive endovascular therapies using coils, stents, or a combination of the two devices for minimally invasive treatment of aneurysms of the lienal artery were reported in 1990, 1994, and 1995. The respective shape and, above all, the width of the aneurysm base, small neck or wide neck, determine the choice of treatment today. For example, by means of coiling in small neck aneurysms or placement of covered stents or Viabahn devices in the case of a wide neck aneurysm. In the case of a very wide aneurysm base and thus a largely absent neck, coiling is primarily prohibited due to the existing increased risk of coil dislocation or protrusion of coils into the lumen of the original vessel with consecutive partial or complete occlusion of the same. A proven therapy in this case would be the placement of a covered stent as a bridging tool in the form of a vial to safely eliminate such a lienal artery aneurysm, or in the special case of a recent rupture of the vessel. The use of the Comaneci device, which has been successfully used in interventional neuroradiology for several years, for the temporary bridging of a wide neck aneurysm neck, for the immediate subsequent positioning of coils in the aneurysm sac, makes this possible without the risk of coil dislocation. After complete filling of the aneurysm, described as so-called coil packing, the Comaneci device is then removed again. The final angiographic controls describe a technical success of up to 98% without coil dislocations in the trunk vessel carrying the aneurysm. Instead of the Comaneci device, similar success can be achieved to prevent embolization of placed microcoils in a wide neck aneurysm to protect against coil dislocation with a bare metal stent bridging the aneurysm neck. Coiling is then carried out through its meshes using a microcatheter. Another treatment option in the elimination of an aneurysm is the temporary placement of a deployed balloon catheter at the level of the aneurysm neck, with microcatheters already positioned in the aneurysm for microcoil application in the aneurysm sac. After successful occlusion of the aneurysm sac, the balloon catheter is deflated if it is angiographically confirmed that no protrusion of microcoils into the parent vessel is recognizable during their application. Both techniques described therefore serve to prevent microcoil dislocations during embolization. According to the results of the literature, the positioning of the vena cava chosen in our case offers no difficulties in placing it precisely, even if the course of the lienal artery is more tortuous. The positioning of a so-called flow diverter, or the use of the double microcatheter technique for the staggered application of longer microcoils, which become entangled during the successive advancement into the aneurysm and thus lead to the elimination of wide neck aneurysms, are further alternative applications. These are some minimally invasive endovascular transcatheter treatment options for aneurysms of the lienal artery. The rapid onset of angiographically proven technical and thus also clinical success of aneurysm elimination using a Viabahn selected in our case is reported in the literature as between 86%, 94%, and 100% technical success, depending on the location of the aneurysm in the visceral vessels. The 100% technical success reported by some authors referred to a total of 2 lienal artery aneurysms that had been eliminated using Viabahn. Unfortunately, technical difficulties in the positioning of Viabahn devices, as in the case of our 63-year-old patient reported by us, cannot always be completely ruled out. Case report. 63-year-old patient with a known aneurysmal arteriopathy of the thoracic aorta in the sense of an aortic dissection and coexistence with a 2.2 centimeters splenic artery aneurysm discovered by chance in the vascular surgery department of the Buergerspital Solothurn, Switzerland. The interdisciplinary consensus primarily favored vascular surgery or minimally invasive transcatheter treatment to eliminate the splenic artery aneurysm. The dissected thoracic aortic aneurysm detected in the pre-interventional CD of the thorax and abdomen, extending into the abdominal aorta, should only be treated with minimally invasive endovascular treatment using endovascular aneurysm repair after stenting of the lienal artery aneurysm detected by CD. A reverse therapeutic sequence would have allowed access to the lienal artery aneurysm only by fenestration of the endovascular aneurysm repair. For the treatment of our patient's wide neck aneurysm, the use of a Viabahn was chosen from the many known and proven occlusion materials as a significantly less invasive alternative to surgical treatment of the aneurysm by interdisciplinary consensus. Due to a technical complication during the deployment of the first vial, a two-stage angiographic therapeutic intervention was necessary, as shown in the following angiography with elimination of the lienal artery aneurysm by vial placement. Angiography and intervention. After obtaining the patient's informed consent on the previous day, the procedure was performed under local anesthesia using the Seldinger technique with retrograde placement of an F6 sheath via the right common femoral artery. Application of 2,500 international unit heparin among others. This was followed by probing of the celiac trunk with subsequent superselective visualization of the splenic artery aneurysm. Using the F5 Cobra catheter, easy placement of an aneurysm catheter through the aneurysm sac into the splenic hilus with the 0.035-inch amplets super stiff guide wire. Insertion of a curved F8 lock, which stretched the alienals, an ideal prerequisite for the safe placement of a Viabahn. Difficult advancement of the vena cava due to kinking of the first guide wire. Only after insertion of a stiff Terumo wire into the periphery of the splenic artery was the vial successfully advanced into the aneurysm under angiographic control via the inserted F8 sheath into the aneurysm neck. The release and deployment of the Viabahn is only possible by pulling very strongly on the tearing thread unfolding the stent graft. This results in a pronounced kinking of the Viabahn due to discontinuous deployment, with shortening of the stent graft and subsequent misplacement of the same after the Viabahn slips distally towards the splenic hilus with pronounced angiospasm immediately proximal to the aneurysm. Angiographic visualization of unchanged perfusion of the splenic artery aneurysm. Due to the stent graft presenting with kinking in the vessel, probing the proximal end of the first Viabahn is very difficult for the overlapping placement of a second Viabahn planned immediately afterwards. Despite the insertion of various differently stiff microwires, it is not possible to insert a diagnostic catheter or a support catheter via the proximal stent end of the first vena cava. As a result, the intervention was discontinued due to the now existing examination duration of more than 3 hours. the elevated radiation dose, and the injected km quantity of approximately 150 milliliters of a non-ionic contrast agent. The preliminary final check still shows unrestricted perfusion of the aneurysm sac, with technically incorrect placement of the first stent graft. Closure of the puncture access of the right common femoral artery using an F8 angioplasty without further angiographically recognizable local complications. We then planned the continuation of the intervention 2 days later, after the patient had been hospitalized in the meantime for further close monitoring in the ICU. It took so long because a Viabahn longer than 5 centimeters had to be ordered from the supplier according to our specifications. Renewed retrograde access to the AFC under sonographic control. Insertion of a long F8 sheath. Problem-free probing of the celiac trunk and the lienal artery. Subsequent various failed attempts at probing using a diagnostic catheter and guide wire due to the proximal end of the distally dislocated first Viabahn, which could only be probed at a right angle. The sheath required for the Viabahn placement is finally successfully pushed up to the aneurysm using an 8 French guiding catheter. However, this is only possible with increased force. Subsequent successful probing of the first Viabahn using a microcatheter and microwire. Using the former, insertion of a long 0.018-inch advantage and advancement of the same into the periphery of the splenic artery. Positioning of a 0.018 PTA balloon catheter in the first Viabahn with careful manipulation. After dilating and realigning the first misplaced Viabahn using the telescoping technique via the balloon, the 8 French guiding catheter is advanced into the stent graft, and a 0.035 in amplet super stiff guide wire is then inserted via this into the periphery of the lienal artery. Only under significantly increased pressure it is possible to place a second Viabahn in an overlapping technique via this wire after stretching the lienal artery with the sheath slipped back. Only then could the second stent graft be placed without any problems. The final angiographic control shows complete bridging and thus elimination of the aneurysm with a now inconspicuous lumen of the lienal artery in the treated vessel section. Regular perfusion of the splenic parenchyma without evidence of emboli, despite the numerous manipulations in the lienal artery or evidence of active hemorrhage in the spleen. After removal of the catheter and guide wire, the puncture site is closed using an 8 French angioseal. Assessment. Technically very complex covered stenting of a lienal artery aneurysm using 2 Viabahn devices in an overlapping technique with initial dislocation of the first stent graft due to large technically induced unfolding and deflation times and difficulty with resulting misplacement. Difficult placement of the second Viabahn due to the almost right-angled approach to the proximal end of the first Viabahn. Finally, successful 2-step elimination of a 2.5 centimeters wide neck splenic artery aneurysm prior to planned endovascular therapy of a dissected aneurysm of the thoracic aorta, which was detected by CDA and extended into the abdominal aorta. Monitoring and progress. Monitoring of the patient on the ward at half-hourly intervals. RR, pulse, O2 saturation for a period of 5 hours. The patient was discharged the following day to the retirement home and further care by a GP with normal local findings and stable circulatory conditions. Aspirin cardio was prescribed for a further 3 months. The angiographic 1-year follow-up of the treated lienal artery aneurysm and the endovascular elimination together with the vascular surgeons of the dissected thoracic artery aneurysm shows both complete elimination of the dissected thoracic aortic aneurysm without reperfusion, as well as regular perfusion of the lienal artery with completely thrombosed, minimally invasively treated lienal artery aneurysm. Discussion. The first minimally invasive transcatheter ablation of splenic artery aneurysms was described in the early 1990s by Miyazaki and others using gel foam and coils, by McDermott and others in 1994, and somewhat later by Krahman and others in 1995. Krahman and others have already reported on 13 treated patients whose splenic artery aneurysms were occluded using a coaxial microcatheter system that is very suitable for coil placement. Subsequently, various authors have described up to 100% primary technical success of stent grafts for splenic artery aneurysms compared to surgical therapy with a greater risk of complications due to the invasiveness of the therapy potential, in comparison with the minimally invasive transcatheter procedure described by Runk and Krunk 2017 have been described in the treatment of a total of 43 visceral artery aneurysms, 23 aneurysms, and 20 pseudoaneurysms, including 14 lienal artery aneurysms, 4 minor and 1 major complication. Fortunately, however, in all cases, these have remained without permanent consequential damage for the individual patient. In our case, occlusion was indicated due to the increased risk of rupture in aneurysms with a diameter of more than 2 centimeters. In the case of rupture, this size is reported to have a mortality rate of 46 to 47%, especially in the lienal artery in women, for example in multipara, of 25 to 45%, and in non-pregnant women of 10 to 25%. Fever and even transient abdominal pain are described by some Chinese authors as a rather unusual complication, which is probably primarily to be assessed as post-embolization syndrome. Interprocedural complications during follow-up were reported by M. Capucci and others 2017 in 25 patients with 19 aneurysms and 6 pseudoaneurysms, including a total of 12 lienal artery aneurysms with 12%. In the follow-up, 2 of the 24 stents showed migration of the stent, and 4 of the 24 stents showed thrombotic occlusions. However, these were not described as primarily technical. The mortality rate is stated as 0%. In the early days of aneurysm embolization, Krahman and others in 1995 reported out of a total of 13 patients with the following complications. 1. Dislocation of the embolization into the spleen, but without the risk of consecutive procedural splenic necrosis, and 2. The occurrence of a rupture, that is a comparatively narrower vessel, during embolization of a hepatic artery aneurysm in the course of minimally invasive therapy in this patient. In our PubMed search over the last 25 years, no reports of a technical complication of the kind that occurred in our particular case could be found. In this case, it was the relatively minor cause of the stent graft, which could only be deployed discontinuously, that led to this extremely technically complex and lengthy stent graft placement procedure. If it had been possible to place the primarily sufficient 5 centimeters long Viabahn correctly, it would certainly have been an almost piece of cake situation. The reason for our technical complication was due to 3 factors. 1. The Viabahn, which can only be unfolded with exceptionally high tension on the ripcord. 2. Normally, only a slight pull is required for the harmoniously and continuously unfolding VIA track. And 3. The high pushing pressure on the torque-stable, super stiff guide wire for its placement in a stable position with its soft tip in the vessel section close to the splenic hilus. The result was that the first Viabahn could only be unfolded with a kink formation with subsequent dislocation towards the distal end of the aneurysm sac. As the angiography showed, it was not possible to eliminate the aneurysm as planned in the first stage of treatment. Due to the kink formation in the longitudinal alignment of the first Viabahn, the guide wire and the catheter had to be inserted at an almost right angle into the proximal end of the dislocated vial for placement of the second Viabahn in order to be advanced further into. The stable position close to the hilus as a prerequisite for the intended placement of the second longer Viabahn. The stable positioning of the guide wire close to the splenic hilus, over which the second Viabahn was pushed on the second day of the examination, could be held in a safe position close to the splenic hilus, even with an inexplicable amount of force. Although the guide wire snapped back several times from the safe position close to the splenic hilus. In this case, the very rare technical complications were the cause of the time-consuming therapy, which placed high demands on the interventional radiologist in order to successfully complete the elimination of the splenic artery aneurysm. The largely therapy-resistant vasospasm of the lienal artery, caused by the manipulation due to the guide wire repeatedly snapping back from the section of the lienal artery close to the spleen, the long duration of the examination, the amount of contrast medium applied, and the total radiation. Those were the decisive factors that led to the cancellation of the intervention on the first day of the examination. The final control angiography showed an almost unobstructed perfusion of the aneurysm sac. Theoretically, it can be assumed that due to the still recognizable complete perfusion of the aneurysm sac by the first Viabahn acting almost as a foreign body, an increased wall tension due to turbulence in the aneurysm sac was to be feared as an increased risk of rupture of the aneurysm sac. The patient was therefore transferred to the recovery ward for close cardiocirculatory monitoring of blood pressure, oxygen saturation, pulse, and local findings in the groin. During the second therapy attempt, 2 days later, it was then possible to place the second Viabahn with new guide wires, catheters, a longer sheath, and a longer Viabahn, which was manufactured by the producer within 2 days, but only with increased technical effort. The proximal entrance of the first-placed vial could only be successfully passed at an almost right angle, and the torque-stable stiff guide wire in the splenic hilus near the distal section of the vessel could only be held in this position with increased longitudinal pressure on the guide wire. It repeatedly threatened to spring back from this position. In this interplay of pressure on the guide wire and overcoming sliding friction forces on the second Viabahn during positioning, it was then possible to overlap it. Angiography showed complete elimination of the wide neck aneurysm with an unconstricted lumen of the splenic artery. These considerable technical application difficulties have not been described in our PubMed research in recent years. A safe alternative would have been to close the aneurysm by using a Comaneci device and protecting it from coil dislocations in order to then safely perform coil packing in the aneurysm sac via a catheter previously inserted into the aneurysm. This methodical technical procedure with the protective temporary Comaneci device is now recommended and has been tried and tested in interventional neuroradiology for some time in order to safely avoid dislocation of coils for small and especially wide neck aneurysms. The situation is different with the use of stent grafts, which do not require microcoil embolization for endovascular elimination and achieve a comparable result in aneurysm elimination. In our case, we had not anticipated such difficulties with positioning and unfolding. We had assumed that the Viabahn track placement would be a regular process. The question we asked ourselves after the successful implementation of the intervention was why there were hardly any reports of such complications. Learning from the experience of others should always be seen in terms of optimizing patient care. One possible explanation for the lack of notification of such events could be: 1. Interventional radiologists work very carefully and cautiously, which can be assumed, and/or 2. There is a lack of willingness on the part of the authors not to publicly discredit their own professional expertise by making such statements. However, this is always regrettable from the point of view of the learning and teaching effect, especially as complications in interventional radiology, as in any other medical discipline, are unlikely to be avoidable. In our opinion, it should always be a high priority, especially for didactic reasons, to communicate how the examiner was able to control a complication by his own means in the sense of complication management in order to achieve the desired positive result. Surely you only learn from the mistakes of others for the benefit of the patient. This topic has been dealt with for some time now at specialist congresses as part of workshops under the motto of complication management. My worst case, and what would you have done? The Viabahn used by us to eliminate the splenic aneurysm in the treatment of small neck and, above all, wide neck aneurysms has also been described by other authors as very good for bridging with subsequent elimination of splenic artery aneurysms. This is not only feasible if the vascular anatomy of the lienal artery is almost normal, but there are also reports of treated cases in which the lienal artery leaves the superior mesenteric artery. In this anatomically very rare vascular anatomy, the risk of rupture is still classified as significantly higher, and therefore requires even faster and more effective removal of aneurysm after diagnosis. The special feature of the situation is that in the event of an aneurysm rupture, two important visceral vessels would be affected at the same time, with a significantly increased risk of bleeding for the patient. The Viabahn is now a firmly established device in the elimination of aneurysms in the arterial pathway. Technical difficulties such as those described by us are likely to be an absolute rarity and will hopefully remain so. Conclusion. For many years, interventional radiology has been offering an increasingly wide range of minimally invasive methods for the elimination of aneurysms and pseudoaneurysms. Here, pars pro toto, coil placement is very successful in the case of small neck aneurysms, and in the case of wide neck aneurysms, the placement of a Viabahn or under the protection of a stent or a passenger inflated balloon catheter, so-called coil packing with complete filling of the aneurysm with a very long coil or several coils. Furthermore, the use of the Comaneci device, an asymmetrically expandable, stent-like, and retrievable device, which is precisely positioned in the sac of the wide neck aneurysm to prevent coil dislocations during its placement, protects against coil dislocations during its placement. Before positioning the coil, however, the methodical procedure involves first positioning a selective catheter in the aneurysm so that the coil can then be placed under the protection of the Comaneci device. Another application option for coils is to insert long coils into the aneurysm sac, one immediately after the other via two microcatheters, whereby the length of the coils causes them to interlock and thus form a ball with a very low risk of coil dislocation due to the application technique, which in our case is due to 1. The numerous repositionings of a torque-stable guide wire required for repeated retraction from its position close to the splenic hilus. 2. The faulty unfolding of the first Viabahn with kink formation of the therapy-resistant vasospasm caused by the numerous manipulations that have occurred. 3. The increased amount of contrast medium injected. 4. The applied radiation dose. And 5. The long duration of the examination were the reasons for the cancellation of the attempted and primarily failed aneurysm removal on the first day of the examination. This was the only logical decision to cancel the intervention at this point. Knowing full well that the aneurysm, which had only been primarily treated but was still fully perfused, would be even more at risk of rupture due to the altered flow conditions in the aneurysm sac. In this case, altered flow conditions with the generation of turbulence in the aneurysm sac with consecutive increased vessel wall tension in the aneurysm are to be assumed due to the misplaced first stent graft. The change in the choice of interventional material used led to the successful elimination of the 2.5 centimeters lienal artery aneurysm 2 days later, while the patient was hospitalized on the recovery ward. In conclusion, It should be noted that in very rare constellations, a proven and primarily very good and efficient minimally invasive therapy to eliminate an aneurysm can unfortunately not always be carried out as a so-called piece of cake therapy. In such cases, a very careful assessment of the situation is required in order to be able to successfully complete the therapy with great angiographic experience and the use of various guide wires, balloon catheters, and sheaths adapted to the changed situation. The 1-year final follow-up of the dissected aneurysm of the thoracic aorta using a fenestrated endovascular aneurysm repair for the outflow of the celiac trunk, that of the superior mesenteric artery, and that of the outflows of both renal arteries after the previous removal of a 2.5 centimeters large lienal artery aneurysm impressively demonstrates the efficiency of minimally invasive endovascular therapy. However, as in our reported case, this may not always proceed primarily without complications. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.